Hello students, welcome to today's session. Another one in the quick Revision Pediatrics Series, and the topic we are going to discuss today is genetic disorders and inborn metabolic errors. So first let's begin with the Mendelian inheritance. The Mendelian inheritance discusses 4 patterns of inheritance. They have the autosomal and the X-linked basically. In the autosomal and X-linked, you have the dominant and the recessive. So you have autosomal dominant, autosomal recessive. These are from the non-sex chromosomes. And then you have the sex chromosome related, that is the X-linked dominant and the X-linked recessive. So let's begin with the autosomal dominant. Now autosomal dominant conditions are where the gene which is expressed is on the dominant chromosome. So it's essentially always expressed. So the abnormal gene is always expressed in autosomal dominant conditions. So when a child has an autosomal dominant condition, there will be an affected member of the family which is going to be present in every generation. So that is autosomal dominant. Examples are achondroplasia, common example hereditary spherocytosis, Marfan syndrome, Gilbert syndrome, tuberous sclerosis, etc. Now autosomal recessive. Autosomal recessive are those type of inheritance where one chromosome carries only a part of the disease. So for the disease to be expressed, you need 2 affected chromosomes or 2 affected genes on the chromosomes. So these 2 abnormal genes together when they are present and there is no other normal gene, then the presentation of the disease becomes apparent in the child. That is autosomal recessive. Having only one abnormal gene on the chromosome in such conditions brings about what is called a carrier state. Autosomal dominant conditions have no such carrier state because only one gene is present which is abnormal and that is always expressed. Recessive conditions require 2 genes to be abnormal and both together in one individual for the disease to be expressed, which means they have no normal gene for that chromosome at that gene level. There is no normal gene at all. So the disease is expressed. So in conditions like this, inheriting one abnormal gene and one normal gene will cause the abnormal gene to be suppressed and the patient will be outwardly normal, but on genetic testing they will come out as carriers. Now examples for autosomal recessive conditions are, you must remember these: sickle cell anemia, Thalassemia major, 2 very important hematological conditions, cystic fibrosis, galactosemia, Gaucher's disease, Niemann-Pick disease, phenylketonuria. These are all some of the examples of autosomal recessive. So let's just write them down. Autosomal dominant HS, hereditary spherocytosis, Marfan syndrome, MS, Achondroplasia, Gilbert's, tuberous sclerosis, etc. Autosomal recessive, thalassemia, cystic fibrosis, sickle cell anemia, glycogen storage conditions, Gaucher's, Niemann-Pick. Now these all are autosomal recessive conditions. Now coming to disorders of the sex chromosomes. Disorders of sex chromosomes are X-linked dominant conditions, which means the abnormal gene is on the X chromosome and it is a dominant gene. So that gene will always be expressed, especially whether it's a girl, whether it's a boy. If it's a dominant gene, it will be expressed. So X-linked dominant, what are the examples that we have? We have incontinentia pigmenti, Rett syndrome, vitamin D resistant rickets, then structural malformation of brain called lissencephaly. These all are X-linked dominant conditions. Now coming to X-linked recessive, the most common which you all have heard of is hemophilia A and B, Duchenne's muscular dystrophy, albinism. So these are the common X-linked recessive conditions. X-linked recessive conditions are essentially almost always present in boys, because in the girl, the X-linked recessive condition will end up being a carrier trait. Okay. Now coming to mitochondrial conditions. Now mitochondrial conditions are conditions which are carried by a group of DNA which are not in the nucleus but in the mitochondria. Now remember, when the zygote is formed, the cell and the cellular cytoplasm and mitochondria and all the organelles are from the mother, whereas from the father it's only the nuclear DNA, the haploid DNA, which enters into the oocyte to form the zygote. So there is no paternal mitochondria entering into the formation of the oocyte. So essentially mitochondrial inheritance means essentially from the mother's side. So the mitochondrial inheritance conditions come from the maternal inheritance. Examples for mitochondrial inheritance are mitochondrial encephalopathy, lactic acidosis and stroke-like episodes called MELAS, Leber's hereditary optic atrophy, Leigh disease. Now these all are mitochondrial inherited diseases. Now coming to Y-linked conditions. Now I had discussed this in my detailed class on this. These are essentially a very small set of genes which are carried on the Y chromosome. So these are essentially inherited from fathers to their sons. So what do you have here? Here you have hairy pinna, the typical baldness or the early onset of loss of hair and baldness. These are essentially the inherited on the Y chromosome. Okay. Moving further, what are the chromosomal anomalies which are important? Let's focus on those. Coming to Down syndrome, the most common abnormality with intellectual disability among the chromosomal disorders is Down syndrome. The frequency of Down syndrome is 1:800 and 1 in 1000 live births, but this frequency varies and depends upon the advancing maternal age. Now, this frequency, what has been given here, is essentially for the advanced maternal age frequency. As the mother becomes younger and younger, the age comes younger, it becomes safer, and the chance of Down syndrome are less likely. The more advanced the maternal age, the more high frequency you will get. So, this frequency is directly proportional to the maternal age. Coming to the genetic cause of Down syndrome. Now, Down syndrome is primarily thought to be trisomy 21. This comprises the large segment of Down syndrome, which is almost 95%. The remaining 5%, what happens? In that, 4% is because of translocation disorders and 1% is what is called mosaic disorders. Now, these are a much smaller percentage, 4% and 1%. But however, what is important? Why is it important that we are mentioning this? Now, this trisomy 21 is what is commonly seen in the common advanced maternal age. The translocation and the mosaicism. Now, this is what we see among the younger mothers. First pregnancies. And these are more likely to be repeated in subsequent pregnancies. That is why it is important to know whether what type of Down syndrome, what is the cause of the Down syndrome. Is it a trisomy or is it a translocation or a mosaic? Clinical features of Down syndrome are very clear. You will have to go from head to toe, but it's classically written by 3 points. One is there are congenital anomalies internally. There's classical facial features and dysmorphism along with intellectual disability. So facial, external, phenotypic abnormalities along with internal organ congenital anomalies and intellectual disability. So head to toe, what are the things that you see? You can see microcephaly with flattened occiput, sloping forehead, upward slant of palpebral fissure, which used to be called the mongoloid slant, but this term is no longer used nowadays. You have the presence of epicanthal folds, flat nasal bridge, widely spaced eyes or hypertelorism, a protruding tongue because of macroglossia, small dysplastic low set ears, short neck, short sternum. You have short sternum because essentially you have only 11 pairs of ribs. You have the simian crease in the hand, which is the single transverse palmar crease. You have clinodactyly of the fifth finger. In the feet, you have sandal gap, which is increased gap between the great toe and the next toe, The Kennedy's crease is the crease which follows beyond the sandal gap into the sole. And these are all the pictures of various children with Down syndrome. You can see the epicanthal fold. Here, clearly you can see this is the epicanthal fold. This is the hypertelorism, you can see. The low set ears which are present. This is the short and curved finger. This child does not have the simian crease. Simian crease occurs when it is a single transverse palmar crease like this, then it is called simian crease. But simian crease is normal in 1 to 2% of the human population as well. And about 10 to 15% of Down syndrome need not show simian crease. Here you have the microcephaly, flat nasal bridge, macroglossia. This is the sandal gap. So these are the features of Down syndrome. Now coming to the congenital anomalies of Down syndrome. We have just finished the external anomaly which are seen in the dysmorphism. Now we are going to look about the congenital anomalies. So looking at each system, in the central nervous system, what do you have? You have developmental delay, you have hypotonia. In the cardiovascular system, classically you have the endocardial cushion defects. You also can have, just without the endocardial cushion defect, you can have AST, VST or PDA. You have hypothyroidism, infertility and obesity as a part of the endocrine abnormalities. Gastrointestinal system, typically it is the Hirschsprung disease which is commonly duodenal atresia, annular pancreas, and all of it presenting with prolonged jaundice in the neonate. All of these, hypothyroidism, annular pancreas, duodenal atresia, all of this will also present with prolonged jaundice in the neonate. Musculoskeletal system shows lot of toned abnormalities. So you have hyperextensible joints, pelvic dysplasia and atlantoaxial instability, which is what the hyperextensible joints also result in. Then hematologically, you can have acute leukemias, of which acute myeloid leukemia is most common. But the good thing in here is that the prognosis of acute myeloid leukemia and Down syndrome is much better than the AML in other children. In the immune system is also depressed and you have recurrent infections. Skin is dry, has seborrhea. Eyes and ears show squint, cataract, nystagmus, congenital hearing loss. All this can occur. Now, what's the one thing you should know is all these features in the neonate become a little difficult to distinguish because when newborns are born, there'll be some bit of caput, there'll be some bit of swelling in the head, in the face, around the eyes. So it's very difficult to exactly pinpoint Down syndrome in the neonate. So what do we have? We have certain criteria called the Hall's criteria. Now this is an MCQ. Which criteria are used to diagnose Down syndrome in the neonate? Which is the answer is the Hall's criteria. Now, how do you investigate? The only way to investigate is by, there are two types. When they say investigate, there are two sections. One is investigate to diagnose. Another one is investigate to see the extent of the congenital anomalies. So, investigate to diagnose is only the karyotyping, where you will see trisomy 21. Now, when you do not get this trisomy 21 is when you have to do a detailed genetic mapping. Now, here's where you'll pick up the translocations and the mosaicism. Now, other investigations are these are for identifying other congenital anomalies. For that, you look at the heart. So, we echo. You will need erect X-ray abdomen because we thought duodenal atresia, annular pancreas was there, Hirschsprung's disease was there. So, erect X-ray including chest X-ray, ultrasound abdomen will be required. Thyroid function test, gynecological evaluation for infertility and the thyroid function test for hypothyroidism. Management essentially is only supportive care. So essentially what you have to do for the child, supportive care. The supportive care includes management of the congenital heart disease or relieving the obstruction of duodenal atresia and all these things. The management of the hypothyroidism, this is supportive care. What for future? You need to have genetic counseling done for the parents so as to predict the risk in the subsequent pregnancies, which is why I told you the importance of the mosaicism and the translocation was there. You have to have a multidisciplinary approach. One person cannot manage the cardiac anomaly and the gastrointestinal surgery. So you have to have a good team of pediatric surgeon, cardiothoracic surgeon, and an endocrine specialist, plus a geneticist, everybody talking to the family and the managing the child together. Special schools are there. Now, one important thing I want to tell is there are special charts, special growth charts. for Down syndrome. So this is something you should know. Down syndrome children's growth is not plotted on the common WHO chart. There are special charts for boys and girls of Down syndrome, and you must plot their growth, head circumference, weight, height on those charts. This is the karyotype of Down syndrome. Here you can see the Trisomy 21. Okay. This is the X-ray. You can see the double bubble. So this is the double bubble appearance. Double bubble appearance of duodenal atresia. You can also see, now if I count the number of ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So you have 11 pairs of ribs. Now coming to antenatal diagnosis in Down syndrome, very important. The antenatal diagnosis of Down syndrome can be done as early as the 9th and 10th week scan. The 9th and 10th week scan, the absence of the nasal bone. Absence of the nasal bone along with an increased nuchal fold thickness should predict that this child may be having Down syndrome, and that pregnancy should be watched cautiously. Early in the second trimester, obstetrics performs what is called the Quadruple Screen. Quadruple Screen contains 4 tests. The first one is the free beta HCG, second one is the unconjugated estradiol, third is inhibin, and fourth is alpha fetoprotein. And this helps to predict 80% of the pregnancies which are going to have Down syndrome. Amniocentesis and karyotyping are done, especially when the parents have had a previous experience with child with Down syndrome, or when all these are highly high. So that time the parents want to be very sure that this child is having Down syndrome before planning for termination. Yes, then amniocentesis and karyotyping is done. Nowadays, before doing something as invasive as amniocentesis, which can also cause loss of pregnancy because of the procedure, we do something called detection of cell-free DNA in the maternal blood. This is the presence of the fetal cells which are roaming in the maternal blood. This is not invasive as such, does not risk the fetus, but it has 98% accuracy. So this is what is followed nowadays. Now coming to Turner syndrome. Now Turner syndrome is a chromosomal disorder where you have loss or partial expression of one X chromosome. So you have 45 chromosome and there is no other X. It is just X and 0. So that's only one X inherited among the sex chromosomes. So obviously this is always in females, and the cause is because of non-disjunction of the X chromosome. The other X chromosome did not disjunct into 2, so no X has come to one cell. That X cell was fertilized by a normal haploid parent cell. So that is when you have the X0 chromosome of Turner syndrome. Clinical features: Turner syndrome girls always have very good normal intelligence. They are short stature, they have triangular faces, hypertelorism, they have high arched palate, may have sensorineural hearing loss. Classical among this is the presence of this webbed neck. This is very classical of Turner syndrome. The webbed neck, the shield chest with the wide space nipples. Cubitus valgus can also be seen. Primary amenorrhea with infertility is there. Internally, they can have the horseshoe kidney, coarctation of aorta, lymphedema, hypothyroidism, and ultrasound will show, because of the lack of the X chromosome, ultrasound shows streak ovaries and a very rudimentary uterus. Management here, essentially, there is no, you cannot give the X chromosome inside. So it's monitoring of growth, supportive care, making sure there's hormone replacement therapy is required. In case there's cardiac involvement with coarctation, then surgery for that. Hypothyroidism, then supplementation of thyroxine and things like that. This is how you proceed for management of Turner syndrome. If you look at the chromosome pattern, this is how it looks. So here, if this was a boy child, you should have had a Y chromosome. If this was a girl child, you should have had 2 X. So here, this is a girl child, but with only 1 X chromosomes. That is why it is the Turner syndrome. Coming to Noonan syndrome. Noonan syndrome is an autosomal dominant syndrome. This has multifactorial inheritance with mutations in 8 genes. It is also called the female pseudo-Turner syndrome or the male Turner syndrome. Now, what are the clinical features? Clinical features are, you have a large philtrum with a groove. You have cryptorchidism. Intellectual disability or developmental delay. developmental delay, thrombocytopenia, you can have cardiac anomalies, which are hypertrophic cardiomyopathy, pulmonary stenosis. These all can be present in children with Noonan syndrome. Now coming to Klinefelter syndrome. Klinefelter syndrome is another 45 chromosome inheritance in which the chromosome inherited in the sex chromosome is XXY. This is also caused by non-disjunction of the X chromosome. However, here what has happened, in turners, one chromosome which didn't have sex chromosome was fertilized with the one which had one X chromosome. Here, the other one which inherited both the X chromosome is fertilized with the Y chromosome. So, you have 45XXY. This is obviously observed in males and is the most common cause for hypogonadism and infertility in males. So, essentially, because of that, you won't have gynecomastia, you won't have testicular atrophy, cryptorchidism, poor secondary sexual characters. You also have tall stature, behavioral abnormalities. You can have aggression, all these things, rage behaviors, speech delay, learning disabilities, hypospadias. These are all the various clinical features in children with Klinefelter syndrome. How do you manage? Essentially, all this you have to manage in the same manner. There's no way you can correct the genetic defect. What you have to do is you have to see how, if there is hypothyroidism, if there's hypogonadism, hormone supplementation can be done, and in case there's gynecomastia, osteoporosis, you can treat surgically, breast reduction surgeries, and behavioral therapy to be done for the behavioral abnormality, speech therapy. Now, this is how you manage these Klinefelter syndrome children. Coming to Marfan syndrome. Marfan syndrome, the cause is the genetic mutation in the protein fibrillin, which is responsible for the connective tissue. It's an autosomal dominant condition with an incidence of 1 in 5,000. And that is why, because of defective connective tissue, you have defective collagen matrix formation. So, this is how the children are. The clinical features essentially are tall stature. You have, see, these are spindly, spidery, long hands, fingers and toes called arachnodactyly. You have upper segment, lower segment ratio is less. Dolichocephaly, high arched palate, blue sclera, subluxation of lens, myopia, and the subluxation is superolateral subluxation, very small MCQ, superolateral subluxation of lens. Mental retardation can be present. You have the wrist sign or the Murdoch sign. The wrist sign is when you ask the child to approximate the thumb and the little finger over the wrist. You will find that the little finger way overcomes the thumb. That's the wrist sign. You have Steinberg sign. Internally, you have aortic root dissection. You can have kyphoscoliosis, pes cavus, hallux. You can see here. This is the hallux valgus. Dental malocclusion. So, these are all the signs and symptoms what you see in Marfan syndrome. Essentially, tall, long, lanky children where you have very spindly, long legs with little bit of intellectual disability along with all these features. The head is little abnormal in shape, blue sclera. There are vision abnormalities. You'll find superolateral subluxation of lens and Steinberg sign, this wrist sign, all of these. This is the sign which you see, where you approximate the thumb inside the hand, and if a distinct portion of the thumb is extending outside of the wrist, then that is called the Steenberg's sign. What is the metacarpal index? Now, this is a very old parameter. Remember that first. It's a very old parameter. It is hardly used nowadays, is what I have seen. What do? This is to see when you take an X-ray of the hand, you're going to find the various metacarpals of the hand. So you're going to take the length of the metacarpals, add them, and divide it by the sum of the width of the metacarpals. So the sum of the lengths of metacarpals second to fifth metacarpal divided by the sum of widths of the same metacarpals will give you anything 8.4 to 9.5 is normal. Anything above that is suggestive of Marfan syndrome. However, there are lots of other conditions where the metacarpal sign can be positive. Hence, it is not commonly used nowadays for clinching the diagnosis. We prefer to do a exome sequencing and prove that there is Marfan syndrome. Diagnosis and management, essentially you have to diagnosis is by whole exome sequencing, where you're going to have the fibrillin gene deficiency or gene defect. You're going to look at for management of the subluxation of the lens, management of any other associated abnormalities which may be present in this child. That's all the management is. Essentially, they children have near average IQs and they can perform well in their lives. Only thing is that you have to be careful that the child does not have issues in the vision of the child, and that you have to take care of. Watch for the aortic dissection, and the child should always be explained that as they grow older, they can always have this sudden aortic dissection. So that all should be managed if it is present. Otherwise, management essentially involves routine evaluation. I would say routine evaluation of cardia and of the eye along with supportive care. That's about the management of Marfan syndrome. Remember, a differential diagnosis of Marfan syndrome, very commonly asked, is homocystinuria. Homocystinuria is the commonest DD for Marfan syndrome. Now coming to Fragile X syndrome. Fragile X syndrome is an X-linked syndrome. The cause of the Fragile X syndrome is called the triple nucleotide repeat of the CGG sequence. So these triple nucleotide repeats happen in the chromosomal sequencing, and that's what produces Fragile X syndrome. That there is reduced production of the FMRP protein, and this causes the features of Fragile X syndrome. This is one of the most common causes of inherited intellectual disability. What are the clinical features? One, we have already told, there's intellectual disability. Two, there's a long prominent face. Long face with prominent mandible. So there's an overgrowth of the mandible with a prominent mandible. So there's a long face with a prominent mandible. You may have features of autism in these children. And you have macroorchidism. Macroorchidism may be seen in the children with Fragile X syndrome. So the other genetic disorders we'll be going through are Trisomy 18 or the Edwards syndrome. This has growth retardation, prominent occiput, hypertonia, clenched hand with overlapping fingers with cardiac anomalies. Trisomy 13 or the Patau syndrome, holoprosencephaly, midline cleft lip, polydactyly, cardiac malformations. You have Cry-du-Chat syndrome, chromosome 5, Prader-Willi syndrome, microdeletion, the syndrome of obesity, hypotonia, hypogonadotropic hypogonadism, binge eating with feeding difficulties in childhood, behavioral problems, Van der Waals syndrome, cleft lip, lower lip pits and hypodontia, Apert syndrome, craniosynostosis, syndactyly, which is fusion of the fingers, corpus callosum aplasia and cardiac defects, Crouzon syndrome, craniosynostosis, midfacial hypoplasia and proptosis. So with this, we complete our genetic disorders. Let's move on to IEMs. IEMs essentially will have 3 or 4 major categories. The first category is the carbohydrate defects. Carbohydrate defects are essentially galactosemia, inherited fructose intolerance, glycogen storage diseases. So let's begin with galactosemia. Galactosemia is a condition where there's a defect in quality or quantity of the GALT enzyme. The GALT enzyme is the galactose 1-phosphate uridyl transferase enzyme. So these children will have from the neonatal period vomiting, loose motion, jaundice, hepatitis, loss of appetite, failure to gain weight, and they are not able to digest even breast milk. You can have infections, cataract developing, and in girls ovulatory dysfunction. Diagnosis is by evaluation of the GALT enzyme assay. You have to do qualitative and a quantitative analysis to diagnose this. Inherited fructose intolerance, this is by deficiency of the aldolase B enzyme. Here again you will have hypoglycemia, vomiting, liver kidney damage, mental deterioration and seizures. Coming to glycogen storage disorders. Now there are 5 types of glycogen storage disorders. Type 1A is the Von Gerk's disease. Type 2 Pompey's. Type 3 is the Forbes or the Corey's disease. Type 5 is the McArdle's disease. Now we will be discussing these 4 first. So Von Gerk's disease is very important. Glucose 6-phosphatase, very common. Among the glycogen storage disease, Von Gerk's is what we see. Here you have poor digestion or poor metabolism of glycogen. So the glycogen gets accumulated in the liver and kidneys, and since it cannot be used, the child does not have enough glucose stores to synthesize glucose. So the child has hypoglycemia and doll-like faces. Then you have Pompey's disease. Here you have the acid maltase deficiency or the lysosomal alpha-1,4 glucosidase deficiency. There are 2-3 types in this. You have the mild form or the infantile form, where the presentation is very severe and the child succumbs by 2 years. You have the juvenile form, where there's only muscle protein issue, and these muscle defects present as myopathy, where the muscles are unable to use the glucose, and the adult form presents as muscular dystrophy. Type 3 is the limit dextrinosis, Forbes or Corey's disease. Here you have the alpha-1,6 glucosidase deficiency. This is a debranching enzyme which is there in the liver and the muscle. So you have hepatomegaly and accumulation of this limit dextrin. So because of liver and muscle being involved, you are going to have high transaminases. SGPT, SGPOT is elevated in the liver, along with a myopathy and muscular weakness. McArdle's disease is the muscle glycogen phosphorylase deficiency. Here you will have myoglobin is not metabolized, so you have myoglobin in the urine, and exercise-induced cramps and pain in the muscle. This was whole section of carbohydrate. Now coming to amino acid disorders. Amino acid disorders, you have a big list. All of you have gone through this in biochem. Phenylketonuria, the deficiency is of the enzyme phenylalanine hydroxylase. Here what do you have? You have mental retardation, you have a rocking kind of motion of the body, you can have seizures, the child is fair with a blue iris because pigmentation is affected, and on testing you can have accumulation of phenylalanine in the blood. Alkaptonuria, here you have the homogentisate 1,2-dioxygenase deficiency. Alkaptonuria is diagnosed or clinically suspected by the urine standing and giving a blackish color. Ochronosis is seen in the 3rd and 4th decade of life, and this homogentisic acid can be tested and it's found to be excreted in the urine. Homocystinuria, a DD of Marfan syndrome. Here you have the cystathionine beta synthetase deficiency which is occurring in the liver. These children very similar to Marfan's, tall stature, kyphoscoliosis, arachnodactyly, and you have homocysteine elevated in the blood and plasma, and they have tendency for stroke in young childhood. Maple syrup urine disease, here you have the keto acid decarboxylase deficiency. Here the child is sick, you have poor feeding, lethargy, vomiting, hypoglycemia, continuous crying, hypertonia, seizures going to status epilepticus and death, and these branch chain keto acids are accumulated in the blood. Hartnupp's disease is a mutation in the SLC6A19 gene. This Hartnupp's disease can remain asymptomatic even up to adulthood, and if ever symptoms do present, they present like a common DD of niacin deficiency, that is pellagra. Pellagra has diarrhea, dementia and dermatitis. That kind of presentation can be seen, and this affects the neutral amino acid transport. So that was the amino acid diseases. Now coming to the third section, that is the lysosomal storage diseases. This is a very favorite of most MCQ paper setters. That is the mucopolysaccharidosis. The mucopolysaccharidosis are mainly of two types, the MPS 1 or the Hurler, MPS 2 or the Hunter syndrome. MPS 1, which is the Hurler syndrome, is the alpha L iduronidase deficiency. Here you have mental deficiency, skeletal abnormality, gibbous in the spine, corneal opacity and joint stiffness, along with classical facial dysmorphism of the coarse faces of Hurler syndrome will be there. Similarly, in Hunter syndrome also, you have the iduronate sulfatase deficiency. Here also, you will have very, very coarse facial features. The Hurler syndrome is not as coarse facial features as you see in Hunter syndrome. Thick protuberant lips, very prominent maxilla, protuberant forehead. This is all very obvious in Hunter syndrome. Hepatosplenomegaly, you have skeletal deformity, short stature, kyphoscoliosis, deformities in the hands and feet, cardiac respiratory diseases, along with mental retardation and ocular disorders. Tay-Sachs disease. Tay-Sachs disease is because of deficiency of hexosaminidase A, and this results in the deposition of this sphingolipid in the brain. So what happens? Tay-Sachs disease, from the neonatal period, there is exaggerated startle reflex, cherry red spot on the fundus, macrocephaly, developmental delay, hypotonia and seizures. Gaucher's disease, deficiency of glucocerebrosidase, and this results in this cerebroside deposition in the brain and the reticuloendothelial system. You have type 1, where you have visceral involvement. You have hepatosplenomegaly, bone pain, anemia and thrombocytopenia. Type 2 is where you have hepatosplenomegaly with CNS involvement, which is classically called the neurogauchers. Type 3 is mild presentation, which is very rare. Niemann-Pick disease. Niemann-Pick disease is sphingomyelinase deficiency. So again, you have the deposition of this abnormal sphingomyelin in the brain and abdominal viscera and reticuloendothelial organs. Niemann-Pick presents very similar to Gaucher's. So you have hepatosplenomegaly with neurological manifestations. The last section of metabolic errors are disorders of purine metabolism. Now we have lots of disorders of fat metabolism, etc. Zellweger syndrome, lots of syndromes are there, but out of these what I have discussed are the most important. So you have the Lesch-Nyhan syndrome. This is an X-linked syndrome with an incidence of 1 in 10,000 males. The defect produces deficiency of the hypoxanthine guanine phosphoriboside transferase enzyme. This results in the accumulation of phosphoribosyl pyrophosphate, which produces the clinical features. They are mental retardation, nephrolithiasis, hyperuricemia, gout, etc. But one classical feature which is seen in Lesch-Nyhan syndrome, it's a self-mutilation syndrome, where the child tends to eat their own fingers, nails, chew pieces of their skin, and that results in self-mutilation. So that is one of the classical clinical features of Lesch-Nyhan syndrome. So with that, I'll be concluding my revision in genetic disorders in IEM. Thank you.